Chapter 20, Cardiac Emergencies. We're going to explore the C in our ABCs and see what we need to do to address these cardiac emergencies. Start off with a review of the basic cardiac anatomy and physiology. Need to review the composition of the blood, knowing the different parts of the blood, the flow of the blood around the chambers of the heart, the right atrium, right ventricle, left atrium, left ventricle, how the blood flows through the arteries, veins, arterioles, venules, and capillaries, and the circulation of the blood between the heart and lungs and between the heart and the rest of the body. So some important things we need to kind of understand as we go through the process here. Helps us understand the diseases and the reactions of the heart to the different problems that are going to happen. The only job of the heart is to pump blood. That's all its only function. There's no generation of hormones, there's no digesting, no processing of any nutrients. It only processes blood. It's a mechanical function, pushes the blood through. It's a pump. It has its own electrical system with its own conductivity system, which generates that electrical signal. So it's always functioning and it's always moving forward for us. So some basic understanding of the anatomy. You get the aorta, which is the first artery coming off the heart, sends the blood to the rest of the body. We have the right coronary artery, which goes around the right side of the heart, supplies the blood there. Then we have the left coronary artery that has the left ascending or descending branch, and then the circumflex that goes around the back. So those are the three main arteries that feed the coronary muscle. So let's talk about acute coronary syndrome. It's also called cardiac compromise. The blood supply to one of those arteries that we just pointed out is blocked somehow. It's a clot, it's cholesterol buildup, it's all kinds of potential problems, but something has got the blood flow to the heart muscle disrupted. When the heart goes without oxygen, you have cellular death. As you start having that hypoxic condition created by the disruption of the blood flow, you start getting ischemia or muscle death. Without that blood flow, the cells die. As they die, they do not regenerate. So you have parts of the heart that do not have blood flow or function the rest of the person's life. So it's important that we catch these when they initially start, get them to the right care, and get that artery opened up so they get that blood flow moving forward again. Most common and most frequent symptoms you run across for acute coronary syndrome is the chest pain. Many different ways to describe it, many different ways people say it. Even the same person has different symptoms if they have the same type of chest pain. They'll describe it as pressure, squeezing, aching, someone sitting on their chest, somebody doing a bear hug around their chest. It kind of depends on where the artery is and what part of the heart is impacted. We also have pain that radiates to the jaw, arm, neck, upper abdomen. The common thing here is that the nerve endings that come from the heart also go through these areas, so the brain senses pain, but it can't isolate the pain, and it gives a signal that you have pain all along that nerve path. Another problem you run into is dyspnea. People that are having chest pain sometimes can't breathe, mainly in older patients and female patients. We also have nausea or vomiting, syncope. Maybe their heartbeat isn't going actually correctly, so they lose some blood, some flow to the brain. Sudden onset of sweating is a very profuse sweat. You'll notice that when you put your EKG pads on, they won't stick because they're so sweaty and they haven't been doing anything. Abnormal pulse, tachycardia, or bradycardia, either one. It could be irregular. And here's the one that almost always occurs, is that impending feeling of doom. They tell you they're dying, and they really believe it. All patients with any type of chest pain, you get your primary assessment, secure your ABCs, get the chief complaint of chest pain, chest discomfort, squeezing in the chest, whatever they want to call it. do your OPQRST to get the history of the present illness, get your past medical history, your sample history, get some baseline vitals, and start moving them towards the hospital. The quicker we get them into the hospital, into a cath lab, the better chance of survival and the better, a larger amount of heart muscle that's still available once they get the reperfusion done. So early symptoms they're probably gonna describe are pain, pressure, discomfort in the chest, jaw, neck, upper arm, belly, possibly difficulty breathing. They'll also describe what we call palpitations, or feels like their heart is beating really strong in their chest. They can feel it beating extra hard. It's because the heart muscle's trying to compensate for those areas that are not getting good blood flow. Sudden onset of sweating, nausea, vomiting, profuse sweating. They just drenched in sweat. They may have syncopal episodes, anxiety, generalized weakness. They just don't feel right. Abnormal pulse, not regular. Maybe the blood pressure's high, maybe it's low. Kind of depends on what's going on in their body at the time, but something's not normal about the blood pressure. When you look at the patient, they're grabbing their chest. They're pointing to the center of the chest that it hurts right there. That abnormal sweating, pale or gray skin, very anxious and restless. Remember, they're having that impending feeling of doom. May have some pulmonary edema. If it's the right side of the heart, they are not able to push the blood completely through the pulmonary system. So it kind of hangs out there and they start getting that pulmonary edema. In reacting to the pulmonary edema, the body tries to shunt the blood down to the ankles and feet, so they'll have swollen edema in the legs and the feet. They will possibly have a medical alert bracelet, necklace. Sometimes they carry their EKG card with them. There's lots of things that'll tell you that they've got a history of cardiac disease. Another good sign is they've got a zipper scar down the center of their sternum where they've done open heart surgery before. It tells you there's a history of heart issues. 12-lead EKGs. As EMTs, you can actually apply the EKG, get the reading, and send it to the hospital. So you'll put the EKG on the patient, you'll hit the send button, it'll pick the hospital, or you pick the hospital you want to send it to, and then follow your local protocols on how that's processed. You are not allowed to interpret. The machines do provide a printout. The accuracy is debatable, but we want to get that EKG in the hands of the physician at the hospital. To do an EKG, first you want to remove the patient's clothing, not yours. Remove the patient's clothing and any jewelry. If they've got nipple piercings in, those can stay in, but any necklaces or anything like that needs to come off the chest. Remove sweat and dead skin cells. So we take a cloth or a towel and start drying off the skin. Trick that I've learned over the years is carry a can of Right Guard spray in your EKG. You spray it on the skin, it stops the sweating, and you can put the EKG pads on. If they have a hairy chest, typically have razors in our EKG kits, so we'll shave just where we need to put the electrodes. You don't have to shave the whole person's chest. Place the electrodes on the chest and make sure they have good secure contact. So placing the limb leads, you do those on each one of the limbs, and they are labeled left leg, right arm, left arm. Place the V1 and V2. They are on either side of the sternum. Then you have 3 and 4 around to the left, and then 5 and 6 even further down on the left. So you kind of circle the chest around the left side. The left side is chosen because that's a bigger side of the heart. So here's where the limb leads. There's a lot of debate whether you want to put them down on the very distal end of the limbs or whether you put them on the thighs and upper arms or shoulders. Go with your local protocols. But you leave your pads on so when they take the EKG at the hospital, they have the same perspective. Limb leads, you got your V1, V2, V4, and then V3 halfway between, then 6 and 5 right between it. So that's important to get these on. We'll practice this in class. We've got EKG machines. We'll practice setting these up. and go from there. You notice there's not much shaving on this chest. We're talking like Robin Williams quality hair that you got to shave. So other thing you want to do is keep the patient in the position of comfort. That's as simple as saying, is it comfortable for you to sit this way? Do they need oxygen? If they are having respiratory distress, they need oxygen. If they are not and their pulse ox is adequate, then you may be putting them on 2 liters of oxygen. We do not want to give them high flow oxygen unless they really need it, because that increases the amount of free radicals that are coming off the dying muscle in the blood into the bloodstream from the cardiac muscle and causing more problems for our body. Low oxygen, low oxygen saturations, high concentration, no respiratory distress, and oxygen sats above 94. We don't give them oxygen. It's not necessary. If you're trained to do the 12 leads, you put those on. Follow your protocols about transmission, and we will look at the EKGs we have here and let you guys practice with that. Administer aspirin, 325 milligrams, or if you're using the baby aspirin, it's 324, but give them 4 baby aspirin by mouth. Have them chew it. They do not give it if they may aspirate, if they can't control their own airway, or they've already had their dose, allergies to aspirin, GI bleeds, or they're already taking a blood thinner. If they've got atrial fibrillation or DVTs and they're on a blood thinner, then you don't want to give them the aspirin again. It just will make things worse. So the aspirin, we prefer the chewable kind. This is the orange flavored, very tasty, much preferred over the other cherry kind. Nitroglycerin is one of those drugs that is starting to not be a primary drug for cardiac. They do have it prescribed to them for chest pain. We're going to keep it as an option, but they have to be having chest pain from that cardiac issue. You give them the patient has the nitroglycerin on their person. So the nitrostat, either the pills or the spray. They have to have a blood pressure of at least 100. So you check the blood pressure. They can't have had Viagra, Cialis, or any other drug for erectile dysfunction within the last 48 or 72 hours. And then you call into medical control and say, medical control, I've got a 65-year-old male, severe chest pain, has nitroglycerin prescribed, blood pressure is over 90 or over 100, over 110, over 90, whatever the blood pressure is, and ask for permission to give up to 3 doses of nitroglycerin every 5 minutes, maintaining a blood pressure of above 100. Doctor will confirm that or deny it, and we'll move forward with what we need to do. After 5 minutes of giving the first dose, ask for the scale of 1 to 10 on the pain. If the pain is decreased, we're making progress. Take a blood pressure. If it's at least 100 and medical control has authorized more than 1 dose, give them a second dose. If they haven't authorized it, ask them if you can. So you're making progress there. But remember, go with your protocol and what's appropriate under your guidelines. After you give the 3 doses, the chest pain persists, get them to the hospital. It's probably not the cardiac issue you're thinking it is, and we need to get them into a medical care as quick as possible. All right, let's talk about some other cardiovascular disorders. Coronary artery disease. You get that cholesterol buildup, the fatty deposits in the walls of the arteries. It narrows them, constricting flow. So you've got that blockage in your pipes, so you don't get a good flow through there. You increase the workload on the heart. It can't keep up because your pipes are blocked, and you start having chest discomfort. Risk factors, heredity. Your family history says there's a high likelihood you're going to have coronary artery disease. As you get older, you have higher risk. Hypertension, if you don't control it, you go into a higher risk factor. Obesity, lack of exercise, elevated blood cholesterol and triglycerides. Smoking. Cigarette smoking decreases the ability of your vascular system to contract and relax when needed. So we'll have chest pain from the insufficient flow. Like I said, the arteries are restricted, you can't get good blood flow, and you need more, and your heart says, hey, slow down, I'm going to give you pain until you do. When you reduce that stress or exercise, then the pain disappears. So I started having chest pain, I sat down, relaxed, and it disappeared. That is angina pectoris. It goes away. Nitroglycerin gets rid of it almost automatically. So it dilates the blood vessel, improves the flow. The heart says, hey, that's cool. I'm good. It's just as good as sitting down and relaxing for a few minutes. If the symptoms go away with rest, then it's angina pectoris. If they don't go away, it may be myocardial infarction. If you have any question, treat them as myocardial infarction. Get them to the hospital that has a cath lab, and let's move forward. Give them oxygen, give them nitro, aspirin, whatever your protocol allows. Get the 12 lead, send it to the hospital, and transport it to the appropriate hospital. Know which hospitals in your region have the capabilities to accept a cardiac alert patient, one that can bypass the ER and go right to the cath lab. Myocardial infarction. Sometimes these vessels get completely blocked with plaque. The plaque flakes off because it's kind of tough inside the vessels, and when they expand and contract, it breaks. Platelets see that break as a break in the artery, so it sends in all the platelets to block it. Well, we don't want it to bleed out there. So your body's responding appropriately. It just didn't realize it wasn't a break of the artery. It was just a break of the plaque on the inside. We can also have a thrombus. One of these clots breaks loose and goes to a smaller part of the arteries and causes a blockage there. They occlude the blood flow downstream. So what we do when that happens is they go in with a cardiac cath, either break up the clot or they put a stent in to increase the diameter of that area, and it puts a little framework inside, like builds a little scaffolding to keep the artery open so the blood will flow. So here's a illustration of what that looks like. So you have coronary blockage right here, and normally we know these arteries go around this area. So this area of the heart here is without blood flow. That doesn't go well when we're trying to pump blood because you don't have a fully functioning heart. So you can't pump the blood as hard as you used to. So ischemia is when the tissue is dying. That's that area that's not getting blood flow. Because the tissue is dead, the conductivity doesn't work through it either. So you start having entryway issues, and the paths are changing, and it changes what the EKG looks like. That's what you hear at STEMI, a ST elevation myocardial infarction. A STEMI is when that electrical pathway changes, and you can identify that on the EKG as ST elevation. Those dysrhythmias will set up a series of events that can cause problems with the heart and actually push the heart into VFib or VTAC. So that becomes the end result. That's a really bad option. Hopefully we catch things when they're still having chest pain and we can get them corrected before we get to that point. Acute myocardial infarction causes the heart to not pump efficiently. If the heart doesn't pump efficiently, then you have hypoperfusion. Hypoperfusion is shock. So being that it's originating from the cardiac system, it's the cardiogenic shock. Cardiac arrest within 2 hours of onset of symptoms is considered sudden death. Most people deny that it's chest pain, that it's cardiac related. I know a lot of people that have had exercise-induced indigestion. Their chest hurts, but it must be the chili dog they ate 2 days ago. It's not cardiac. It can't be cardiac. So denial is a huge issue here. A lot of our sudden cardiac arrests are really not sudden, it's just denied until they get to the death point. Treatment of AMI at the hospital. A preferred treatment right now is balloon angioplasty. They go in with the Roto-Rooter. They also have fibrinolytics, It's kind of like Drano that they put in and it goes through and busts open clots. The complications here is it busts open any clot it finds within the body. So it's as simple as you tried to start 2 IVs and you only got the second one to work. They have a hole in the skin. It will break open the clot there and they will bleed from that clot or anywhere else they may have had any issues. So our preferred method is angioplasty. After the fact, they typically go on aspirin a day to reduce the clotting factors, and then take some beta blockers to reduce the function of the heart so that it doesn't beat as hard and cause as many problems. Treatment of the infarct, myocardial infarction, ABCs, always doing that. And then look for the pattern. The chest discomfort, dyspnea, nausea, syncope, sweating. That's the same as angina pectoris, myocardial infarction, so we're going to treat them all as myocardial infarction until we prove it otherwise. And typically that's not done until we get to the hospital. So every chest painer gets treated as the most serious kind until we actually get where we get definitive care. Get them to the hospital. Apply a large dose of diesel therapy, a nice easy ride, not to get them spooked, but on the way to the hospital, get the EKG. Call ALS. Get them en route. Watch out for cardiac arrest. Do not hook up the AED until they are actually in cardiac arrest, but don't stuff it underneath the bench seat. Have it ready, easily to get to, and maybe keep an extra person in the back just in case. Use your aspirin and nitro based on your protocols. If they have any type of pulmonary edema, now you're talking congestive heart failure. Maybe it's the right side of the heart that's having the myocardial infarction and causing the heart not to pump efficiently to push the blood through the lungs. So they have a hard time getting the blood through the lungs, tissue perfusion's bad, they can't exercise, they get that fluid buildup, things just are not going right for them, so they're having the heart failure. The right side, you get the pressure in the right atrium and the superior vena cava. Jugular vein distinction, they stick out on both sides. You get the pedal edema, swelling in the gut. Left side, you get the buildup in the alveoli. Gas exchange is impaired, lots of pulmonary edema, and typically life-threatening. I mean, remember, the left side is the part that pumps most of the blood around the body. So, assessment of the heart failure, you have a history. Medication for controlling fluid levels, Lasix, big one there. Pedal edema, swelling of the belly and the buttocks, JVD, jugular vein distension, all things telling you the fluid is backing up in the system. So you find pulmonary edema when you do the listen to the lungs, difficulty breathing, crackles, pink frothy sputum, all bad things saying there's backup into the lungs. So for your treatment, you're going to have your primary assessment, may need ventilation, use your OPCAR-ST and sample, get a good history of the cardiovascular system, and take multiple sets of vital signs. That's going to give you some trending really good to help you function there. Treat whatever findings you have. Call ALS. They have some more advanced treatments for pulmonary edema. And just a hint, the preferred treatment for pulmonary edema for ALS is nitroglycerin. It is not for you to use because that's not in our protocols to give nitroglycerin for pulmonary edema, but it's something that you may see. Definitely consider the CPAP. It's a good function there. Aneurysms. We get some type of weakening in the wall in the artery somewhere in the body, and the pressure actually pushes against it and eventually causing it to burst. The aortic aneurysm, the abdominal aortic aneurysm, the AAA, is one of those life-threatening things. You find it when you're doing your belly. You find a pulsating mass in there. Do not call your partner over to say, hey, check this out. The more you poke it, the more likely it is to burst. We don't want that. This is kind of what it looks like. You've got that bubble on top. Eventually it bursts, and in 2 or 3 seconds the person bleeds out completely into their gut. So that's something we don't want to have happen. That treatment is rapid transport to the hospital. So as always, if you have any questions, feel free to jump in there and ask. Bring them to class, and we'll see you there. Thanks. Bye.